In 1996, Intermountain launched an effort we called clinical integration. Prior to that time, most of hospital management had to do with the facility. You had financial budgets organized by departments for facilities management, and the clinical quality kind of belonged to the medical staff over there. The two were separate. We wanted to pull the two tightly together. The key to it was process science, understanding what clinical processes we executed on behalf of patients, the definition of patient-centered care. We found a very strong prioritization. Among more than 1,440 clinical conditions that we identified that we routinely treat inside Intermountain, 104 of them, 7% of them, accounted for 95% of our patient care delivery volume. And we just started to take those one at a time and build them in. You see, quality and cost are two sides of the same coin. W. Edwards Deming is the person who demonstrated that mathematically. It's a proof. Two sides of the same coin. The best way to get good financial results is to manage the clinical side of the equation. Now that means that in your measurement systems, you have to have clinical outcomes, intermediate and final clinical results, tightly tied to financial outcomes, linked together, so it's transparent to all. If you do that, your physicians and nurses will become some of your finest financial officers. Now, they can understand those problems. They know that they have to survive financially. They'll take real pride in finding how to get the best clinical result to drive the lowest necessary cost. It's worked for us. 3 years ago, our CFO, Bert Zimmerly, set a goal for our system. Now we're a charitable not-for-profit. We supply most of the care in our part of the United States. He asked that we limit rate increases to patients to consumer price index inflation plus 1% inflation to individual patients. Now, insurance premiums, fees for services within our system, CPI plus 1. We built a financial plan around that. It meant by last December 2013, 3 years in, we needed to take $400 million out of our cost of clinical operations. That was a little over 10% of our total cost of clinical operations. We made $430 million, about 12%, a little more than 12%. The main source of it was clinical management. Now it's interesting. We took about 15,000 inpatient admissions out of our system last year. I mean, that was the total impact as part of that. It's not just intra-case utilization, how much it costs us to do a case. It's how many cases at a population level. And our finance department, Greg Johnson, Bert Zimmerly, turned that into solid bottom line. We've had some of the most robust operating margins we've ever had in the face of that. It's the funniest thing. If I'm very liberal, we're 35% at direct financial risk, or we get a premium and bear the full cost of the patients. 27% through Intermountain Select Health. That includes our Medicare Advantage plans. It includes the fact that the state of Utah shifted all of Medicaid onto full capitation, and our commercial business, where we're effectively capitated. We get a premium per month. About 8 to 10% of our business is unpaid capitation in spades with a 0% capitation rate. 35%, though, we had not appreciated the leverage that the waste side of the equation had compared to the revenue side. The leverage was dramatically bigger. And so despite the fact that dropping utilization rates hurt revenues in terms of just volumes coming through our facilities, the leverage was so much higher that we've been running well ahead of our budgeted targets for the last 3 years. This year is going to turn out to be the same, just in passing. Our goal by 2016 was to take $700 million out of our cost of operations. That's a little over 15% of our total cost of operations against projected growth, admittedly, at a 6% growth rate. That's where we were running with the Great Recession. We wanted to take it down to about 2%, and we've done it so far. I actually think we'll hit that goal, I hope, cross fingers, next year in 2015, a year early. We'll come close. We'll see. I think the mistake that people make they really should be focused on operating margins. But they've got a surrogate measure they're using of revenues, volume-based revenues. It's an artifact of the fee-for-service system, and it's a mistake. The leverage is so much higher on the waste side that it dramatically overshadows gains from the revenue side. A smart CFO will recognize that, and they will show their organization how to take advantage of it.